a treat. This is a great second part of the presentation, and I have the tremendous honor of introducing Dr. John Bree to us. Again, I'm going to try to do your CV justice, but Dr. Bree has a degree from Tufts University and obtained his MD from St. Louis University. He was a surgery resident. He did a surgery residency as a chief resident at Hartford Hospital in Connecticut. He's a board-certified vascular surgeon and taught surgery as a surgery instructor at the Tufts University School of Medicine, and is also a lecturer at the vascular surgery program at UCSF in San Francisco. We're fortunate to have him practicing here at Alta Base Medical Center as part of the Bay Area Surgical Specialist Group, and he is also the chief of the Department of Vascular Surgery. So, thank you very much for coming.
I can remember my. Can you hear me? Yes. I have to remember my code to get in here. Oh, it's. Well, now that you've heard from the brains of the outfit and Dr. Dirks, I'm going to give a talk about vascular surgery as it relates to dialysis access. I'd like to thank Dr. Dirks for inviting me to speak today, who apparently considers me a worthy opponent to share the podium, and especially the Bay Area Association of Kidney Patients for putting on this program. It's an honor to be here. I've been in practice for about 20 years in all just straight vascular surgery. And I've been fortunate in the last 3 to 4 years to narrow my focus to dialysis access to approximately 90% of my work. It's been a pleasure for me because I specifically really enjoy the combination of the challenges, the multiple challenges in dialysis access and surgery and all the various unique circumstances that come up with the patients. It also allows me to work with the most sophisticated internists in the hospital who happen to be your nephrologists. And finally, in truth, I found that the dialysis patient population has been the most appreciative of the efforts of all the patients that I've worked with in surgery. So it's a delight to be able to do as much as I'm allowed to do. It's remarkable to me that the human heart pumps about 1.5 gallons of blood flow every minute. And in an average, 4-hour dialysis session, we have about 320 gallons that are pumped through our systems. In dialysis, we are drawing off just 1% of that flow in order to clear fluids and toxins from our system. And now, you might say, why not just crank up that rate of flow significantly? Well, in the human body, it turns out that there are certain balances and tolerances of the system to handle this intervention we call dialysis. And here we go. It turns out that if we were to increase the rate of our dialysis by just 4 to 5%, that would increase the rate of return of blood flow to our heart to such an extreme degree that it would risk actually overwhelming the heart in terms of its ability to deliver. Well, I don't want to accept that. All right. So if we return blood flow to the heart, instead of at 1%, we crank it up enough so that we can get this dialysis over in about an hour, we're going to return too much blood flow to the heart, potentially overwhelming its ability to keep up and putting the patient at risk for congestive heart failure. Correspondingly, if this dialysis access here, which is actually just illustrated over here, this connection point anyway, if we're drawing off too much blood flow, also you might understand that we are compromising the amount of blood flow. We're sharing blood flow with our dialysis as well as with our hand. And so if we were to draw off an excessive amount of flow, perhaps just going up by 4 or 5%, we put our hand at risk. Patients can have cold, numb, painful hands, so-called an arteriovenous steal syndrome. The arterial to venous connection for dialysis steals too much blood flow, and patients will have a compromise here. So in order to deliver successful dialysis, we have to work within fairly narrow constraints. Okay. So the long view of dialysis access, this graph presents the total number of patients over the years that have been on that are on dialysis from 1980 through 2012, and a steady rise in the total number this is in the United States. The steady rise in the total number is felt probably related to three major aspects. One, uncontrolled or unrecognized diabetes and uncontrolled hypertension, but also to the increased age of the population. Baby boomers are entering the 65 to 74-year age group, and age just on its own is an independent risk factor for kidney disease. In 2012, we had over 600,000 patients on dialysis across the United States, and of that number, we have a total of about 6.5% of patients are on peritoneal dialysis, identified in the lowest of these, the lower number, the lower curve there. The one step up from that on the gray or brown trajectory there is functioning kidney transplant. There's about 30% of patients, as of 2012, with all patients over time, that have a functioning kidney transplant. About 2/3 of patients following the yellow line are on hemodialysis as of 2012. Now this is a slide, a graph that documents the number of new patients per year arriving at kidney failure from 1980 to 2012. And as of 2012, we had nearly 115,000 new patients on some form of renal replacement therapy, peritoneal dialysis, new kidney transplant, hemodialysis. When it comes to the peritoneal dialysis population, the actual percentage rose from around 6.5% to somewhere just over 8% on peritoneal dialysis. The rate of hemodialysis was up just at or slightly over 80%. And we know that there's only 100% of anything out there, and so what that means is the number of the patients managed with kidney transplant is relatively less. In 2012, there were over 17,000 kidney transplants performed, which is at a rate of about 300 new kidney transplants per year for 2010, 2011, and 2012. The rate of kidney transplantation was at a rate of about 15%. If you notice from the previous slide, there were 30% of patients with functioning kidney transplants. So the bottom line from this slide is that although we have a pretty significant number of kidney transplants, it's not keeping pace, unfortunately, with the rate of kidney failure. The positive news is that you notice that at the top here, there's been a relative drop between 2010 and 2012, and that signifies, most would believe that signifies an increasing recognition and aggressive treatment of hypertension and diabetes in the population. Now my charge today is to discuss, thank you, is to discuss the vascular surgery and dialysis access. Now, to discuss dialysis access surgery, I need to go back to the origins of vascular surgery itself. And we can trace this back to the late 1800s when Jabelet and Brow presented on a dog model, a canine model, the successful sewing of the endpoints of divided arteries in dogs together. And what they recognize is the technique that was presented in a paper. What they recognized was it was terribly important to avoid clotting off what we call thrombosis, clotting off the blood, to evert or outfold the endpoints of the artery so that the inner lining, what we call the intima, is in continuity or connected to the intima of the other piece. That was a significant finding. Alexis Carrel in 1912 was really considered the father of vascular surgery. He perfected the work of Jabelet and Brow. He was from France as well, from Lyon, and undoubtedly had contact with Jabelet and Brow. He perfected the technique by using what we call pexing sutures or traction sutures, and these help to perfectly align the end of the blood vessels and also to ensure an eversion of the endpoint. For this advancement, he received the Nobel Prize in Medicine or Physiology in 1912. He moved from France and became a surgeon at the University of Chicago. Alexis Carrel is known for a variety of quotes. One which is probably best known is, "A few observations and much reasoning lead to error. Many observations and little reasoning to truth." I'm actually more entertained by this one. "There's only one way to ensure that every scientist has extensive knowledge and talent, to reduce the number of scientists." So, moving along, George Haas in 1824 was the first one using an effort to connect to the blood system, to the arteries and the veins at the wrist. He reported the successful first dialysis of a patient during just a 15-minute interval. One other thing to point out at that time is that it was necessary to use a blood thinner in order to allow for the blood to move through these tubes. And originally, one of the major stumbling blocks was solved after a protein named pyruvin, which was extracted from leeches in order to thin the blood, was finally major allergic reactions, was replaced by heparin in 1927, which is still in use today. Willem Kalf in 1943 devised a rotating drum kidney, a kitchen tub, a couple of wooden barrels, and some cellophane tubing. He drew blood from the artery and vein at the top of the thigh into this system. He began in 1943, and in all honesty, the first of his patients survived more than a few days, beginning in 1945. Allwell in 1949 began work on a rubber and glass tubing device that could be mounted and worked on at the wrist. And this was improved upon and really brought to the public in 1960 when Belding Scribner devised a device made of plastic tubing, plastic Teflon, which was inserted into the artery and the vein at the wrist. This was a huge advance. It was a huge advance because, as opposed to patients before this that had to undergo repeated puncture every time they had dialysis, Scribner came up with a device that could be worn externally and that could be attached at each dialysis session. His most famous patient was a man named Clyde Shields that survived 11 years with a Scribner shunt. This is a Scribner shunt. The Scribner shunt was connected by these Teflon tubes into the artery and the vein, and when not in use, a curved tubing was placed between the two so that it could be continuous flow. When in use, that tube would be removed, connected to a dialyzer, and the patient would be dialyzed usually twice a week at that time. This is an actual Scribner shunt. And like I said, it was a huge, huge advance. However, not surprisingly, these patients had problems with infection, they had problems with these clotting off, or just becoming displaced. I would also say that Scribner established the first outpatient dialysis unit at Swedish Hospital in Seattle, Washington, in, I believe it was 1962. This took care of 9 patients at the time, dialyzed twice a week. This was expanded to 47 patients in 1964. By 1977, there were 40,000 patients across the U.S. handled at 600 facilities. And now there's over 10 times that number handled at over 6,000 facilities across the United States. Now, the origins of another approach to dialysis access are found in the history books with James Chimino. Now, Chimino was a Korean War veteran who took a job in New York City, one of the New York City hospitals, as a phlebotomist, meaning drawing blood from patients. Again, in 1960, he recognized that people that had had significant penetrating injuries, and I think to a large extent military injuries where there was a knife or gunshot wounds, some of these patients would develop an unusual connection between the artery and the vein because of this penetration and a healing that allowed blood flow to pass from an artery to a vein. He recognized that these connections were great sources to draw blood from. They stayed open for long periods of time. They had great. It was easy to get the blood. They again stayed open for a long periods of time. He, along with his research partner, his insights and developments brought arteriovenous fistulas to the world of dialysis in a landmark paper in 1966. And I'll talk about some of the anatomy of this shortly. Another fistula, another artery-to-vein fistula, was presented in 1977 by Graz. That of a cephalic vein, another place in the arm where there's a vein that could be a surface vein connected to one of the deeper arteries. And then finally, Barnett in 1979 came to press with the brachial artery to basilar vein. These are 3 different fistulas, again, that I'll spend some time on in a moment. What was common to all of these, they all had high volume flows, which we need for dialysis. They're easy for access at the dialysis unit. Patency, meaning how long it stays open. These would stay open for long periods of time, which would be ideal. Low infection rate. We're not putting a piece of plastic inside that has a higher risk of infection. And as you recall from the first slide where I was talking about not too much blood flow going into your dialysis access, there was a low risk of this steal. So patients weren't developing significant problems with the circulation to their hands. Now, let me make sure that everybody's on the same page. Arteries carry blood flow from the heart under high pressures. We know from our blood pressure that somebody might have a systolic, a number on top of 110, 140, 160, and so forth. The veins in the arm, they carry blood flow very sluggishly back to the heart. If we measure the blood pressure inside of a vein, it might be 0. It might be 5 millimeters of mercury, it could be 10 millimeters of mercury. For this reason, the vein wall is not nearly as structurally sound as that of the artery. If we connect one of these more fragile structures, a vein, to an artery, and we expose the vein to this very high pressure and this very high flows, our hope is that that vein is going to begin to dilate up over the course of time. And hopefully we're going to have something big enough and flow adequately enough for dialysis. Now, Shimino discussed, or not, well, rather presented on, the cephalic vein down near the wrist connected to an artery nearby that's called the radial artery. Roz represented the cephalic vein after it crosses the elbow, and that would be disconnected and then connected to the artery nearby. The brachial artery is what it's called at that level. And then there's the basilic vein up here, which is another option. It's a little bit more complicated, but again, connected up here. That's, in terms of surgery or preparing a patient for a surgery, it's terribly important for me to get an ultrasound to measure the size of these veins beforehand, because there's plenty of patients that may not have a cephalic vein, which is at least 2.5 to 3 millimeters in diameter. There's plenty of patients that may not have a basilic vein, which ideally should be 3.5 millimeters in diameter or larger. So this ultrasound is very important in helping to decide what is going to be the best for each individual patient, and hopefully you've got a vein which is big enough to use. When we do go and prepare a patient and go ahead and create a fistula, we try to ascribe to the rule of sixes. And the rule of sixes is we'd like our vein, once exposed to the artery, to enlarge 2 to 3 times its normal size, up to at least 6 millimeters in diameter, maybe 7 millimeters in diameter. We'd like it to be less than 6 millimeters below the surface of the skin, so that the technician at the unit can feel it easily and it's not kind of a, well, I don't know where it is, so that it's easy to feel. We want it to carry 600 milliliters of blood flow every minute. Because as you may know, those people on dialysis, these machines run at 350, 400, 450, and in some cases 500 milliliters a second. The fistula would collapse if it was too close. So we want these to carry 600 milliliters per minute or more. And finally, we want there to be 6 inches of usable length, so that the needles can be moved around and we can get plenty of time out of our fistulas. Let me spend a little bit more time here. Now, so this is an illustration of a Shimino fistula, which was conceived of by James Shimino. That of disconnecting and tying off the cephalic vein near the wrist. This is the exploded view, and it's swung over literally no more than about 1/2 to 2/3 of an inch, and then sewn to the side of the artery. Okay? Here's a patient, I'm not sure you can see. He's got a this is immediately before an operation. This patient is a perfect candidate for a Shimino fistula. He's got a large cephalic vein near the thumb, travels up and carries along the upper part of the arm. This patient, if this were to have a problem down the line, we'd have another option up here. Normally, as I said, we have 3 options in either arm. So many times, if one set of veins is no good, we can have an excess elsewhere. Now, a different patient had a Shimino fistula. This is a typical incision about a week or so after operation, healing up nicely. That patient is seen here about 6 to 8 weeks later, which is the time that it really takes for these things to really grow. So we need to know about patients as early as possible who are heading towards dialysis so that we can get something ready and you start dialysis with something that's already prepared to go. You can see that this vein, which has grown considerably in size, by this time is ready for dialysis access. So the next that I'll review quickly briefly is the cephalic vein in the upper arm, which is connected to the brachial artery near the elbow. Another exploded view here. The vein is divided and tied off here through hopefully a shorter incision than that, and then hooked up to the artery. This incision can also be made quite a bit lower towards the elbow, so it can actually be above or below the elbow. Here's a patient just before operation. This patient has had a prior surgery related to dialysis access here. That unfortunately is no longer working, and this patient happens to have a good vein in the upper arm. It's a bit deeper, you can't see it, but we know that the artery passes along the inside of the elbow here. The vein passes up the front of the arm there. An incision like this, just after surgery, is typical. It's about an inch, slightly larger than an inch long, and it's possible to get to both of these structures, cut tight, and hook this together. The glistening there, we no longer use dressings. We use a glue on the skin, which seals it so that patients can be back in a shower in 2 days. Now the third of these is the basilic fistula, that of using the basilic vein which travels along the inside of the upper arm. This is a little bit more complicated. These patients, this vein travels more deeply in the arm, and in order to create a fistula with basilic vein, it's necessary. Some surgeons will perform a long incision along the entirety of the arm to expose the vein. I prefer 3 shorter incisions to expose the vein, tie it, cut it here, and then it needs to be moved up closer to the skin, or so-called transposed, so that it's close to the surface, hooked up to the artery near the elbow. And for this, because it's a more complicated procedure, although still an outpatient procedure, it does require a heavier anesthetic, either a nerve block to make the arm numb, or a general anesthetic. And for that reason, the Shimino fistula at the wrist or the brachiocephalic fistula at the elbow is our first choice in this for this. And this is just an exploded view indicating that the basilic vein, which normally travels down behind this muscle here, is cut, and it's been tunneled to the side and along in the front here, then hooked up to the artery there. These other surgeries, the Shimino and the brachiocephalic, they take about 45 or 50 minutes to do. This operation here takes about an hour and 20 minutes, and as I said, these are all outpatient procedures. Here's a patient that's had a brachiobasilic arteriovenous fistula, 3 incisions along the inside of the arm, and we have actually probably more prominent than usual vein underneath the skin, which is ready for use at dialysis. Now the next slide is my only surgical slide, and I tried to make it as inoffensive as possible. If anybody needs to close their eyes, please feel free. I believe that's it. Okay. So this is a patient who's undergoing a Shimino arteriovenous fistula at the wrist. Over here, the vein, the cephalic vein, has already been divided. The other end of it's tied and underneath the skin, and you can see that it's been cut on an angle. There's a little bit of this is actually a very gentle clamp, keeping it closed so we don't have any blood loss. And then there's a side branch of that vein that I tied off. Here, the vein has been and here we have the adjacent radial artery, which has these gentle clamps on it. It's been opened probably 6-7 millimeters in length. The vein is advanced over and sewn down with stitches that are anywhere from about a 16th to a 32nd of an inch separation. We use a monofilament line. It's much like very light fishing line in order to do these. The clamps are removed. Blood flow is released to go to the hand, and also to turn the corner and enter this vein, which now you see is quite distended. And we hope that this is going to grow again 2 to 3 times its size over the course of the next 6 or so weeks. So there were major problems with the Scribner shunt. As I said, clotting off, infection, dislodgement, and also the other subset of people, the ones that had ultrasounds and were found to have veins that were not adequate to create fistulas for, put a lot of pressure on for the development of synthetic and biological grafts for dialysis. In 1972, Dunn presented on a Dacron velour tube graft. This could be sewn to an artery through one incision, tunneled underneath the skin, and then sewn to a vein in another and can be accessed directly through the skin. The same year, a bovine carotid artery could be used. Now, this would be the artery in the neck of a cow that was developed and sterilely prepared for human implantation. And this, when I first went into practice, we did this all the time. And it still is in use today. There are certain settings in which this is a go-to graft. It generally works quite well. Sawyer in 1972 presented on a Teflon graft, a type of plastic expanded Teflon. And in 1976, Baker presented on 72 patients with the same graft. EPTFE is the same as Teflon. And the Teflon grafts or Teflon material in grafts is the go-to even today. And for completion, or to be complete, in 2001, cryo veins and cryo arteries came to the clinical world, that of veins and arteries that were secured from cadaver donors. And again, like the bovine graft, there are unique roles in which these have a place. This is another illustration of sewing of a graft, and I'm going to call this a graft versus a vein, which we'll call a fistula. So an artery has been clamped, opened with a small blade and scissors, and here we see the graft, which is being sewn down in much the same way that a vein would be. So grafts can be placed in multiple different configurations. Our first choice is usually to make a connection at the wrist and the radial artery, as we saw before, and have it as a straight graft traveling along. But occasionally you'll have a patient that's had either prior surgery at the wrist, or the artery is just too small to carry that 600 milliliters of blood flow that we really need. This illustrates the insertion of the positioning of a loop graft in the forearm connected to a larger artery here and a vein there. There are corresponding straight and loop grafts that can be inserted into the upper arm as well. Now, in settings in which the artery is perfectly capable of handling that blood flow, but because of prior surgeries, perhaps the vein up near the armpit is scarred or too closed, and we just don't have that as access, which happens to be the case, fairly frequently. We may turn to a hero device. A hero device is a combination of a regular Teflon graft that's sewn to the artery here, and it converts through a titanium connector into a single tube that is inserted in surgery into the jugular vein at the base of the neck. Patients are generally under a general anesthetic for this. The end of that tube just exhausts the blood flow into the central veins of the chest, so there's no need to have enough vein to make a sewn connection. If there's not an option in the arms for one reason or another, we may turn to a thigh loop graft. Here we have the artery and the vein as the inflow and the outflow, but this has the inconvenience of being dialyzed on your leg, as well as a higher rate of infection of these grafts because of the physical location. And beyond that, once we've kind of run out of a large variety of options, then there are much more exotic options, which are illustrated to a certain extent over here, pretty much limited by the creativity and almost imagination of the surgeons to find further options. Here's a patient that's had insertion of a straight forearm graft, an incision over the artery, incision over the vein, and there's a subtle ridge here through which the Teflon graft is passing. So with this slide, I want to convince you that a fistula exceeds a graft, and why why we put so much pressure to try to create a fistula under almost any circumstance. Now with a fistula, our infection risk, because it's all new. We're not putting a piece of plastic in, we're connecting your vein to your artery. The infection risk is not quite zero, but it's nearly zero. Whereas with a graft, even with antibiotics given at the beginning of the procedure, the infection risk is 3 to 4%. anesthesia for a fistula is mild. Tends to be local anesthetic, and the anesthesiologist gives some sedation, so you're kind of looped. But it's a fairly mild undertaking for the schienophystular risk, brachiocephalic at the elbow. I would admit that for a brachiophacilic in the upper arm, that's going to be a moderate anesthetic and possibly a general anesthetic for those. Grafts unilaterally require either a regional block of the arm or a general anesthetic. So there's some increased risk in patients with that approach. The steel risk is low. That's where the graft of the fistula takes too much blood flow and your hand can get cold and numb. Very low risk with veins. That's probably because the vein begins as a much smaller size than the plastic tube of a graft, which draws off immediately at a large volume. The body seems to accommodate that rate of growth and shares it between the hand and the body much more successfully than a graft. Patency rate, that means how long it stays open. Patency rates of fistulas, 2 to 8 years for the most part. Grafts, 9 to 18 months, frequently at the lower end of that range. Healthcare costs low, we're not taking anything off the shelf. With a graft, these grafts that we're using can range anywhere from about $800 to $2,500. And then the only negative aspect of a fistula, it takes that time for it to grow to 2 or 3 times its size. It can take 6 weeks, 12 weeks, and even longer for it to be ready to use. Access of a graft, certain grafts are ready to use in 1 day, okay, or up to 10 days. But all in all, there's a huge advantage in patients if we can get fistulas to work. Okay. Okay. So the next stage, the next level of technology came with the Gore company releasing a hybrid graft, a graft which has a combination of a stent portion and a graft portion. Now, many patients have had an upper arm dialysis graft of sorts. They have scar tissue up there. We may see by ultrasound that in fact the vein is open, but there's just not enough length for us to get a full length sewn connection, what we call an anastomosis there. This is a perfect opportunity for us not to have to jump to the opposite arm, but to remain on this side and to use this technology. So with this technology that I'll try to demonstrate here, all I need to do, or all it needs to be done, is for a relatively small incision to be made in the arm, and to have access with a. Wish I played more video games. Anyway, so. In this situation, all I need to do is be able to get a needle in, a floppy wire is advanced in, a catheter is put in there, which is a sheath, and then over that sheath, we put in this device, which I want to try to illustrate for you. Notice that there's the device which has a very narrow straw kind of at the end of it, that's just going in now, okay? That is the stented portion, which is not deployed, it's not released and open. We can advance that down through this peel-away sheath and allow us to go over that floppy wire that's inside. Once that stented portion is inside, the ripcord is pulled, the stent is deployed, and then we inject X-ray dye in to make sure that we're in a good position. Once we're satisfied with that, a balloon is advanced across the stent to inflate and to secure it to the wall of the vein. Once again, to make sure we haven't had a problem with the balloon treatment, we inject again to make sure that things are good, are secure. This device allows us to go a good 6 to 10 centimeters higher up, well above where we could go surgically. The graft is then advanced through a curvature down into the arterial exposure above the elbow. It's sewn to the artery, the clamp is removed, and blood flow is released into the graft. This is a temporary dialysis catheter. This is our final option for dialyzing a patient. You can see this is a chest X-ray in a patient, and this is the catheter which goes through the skin and actually hangs it out on the wall, along the chest wall of a patient. And it's positioned in the veins, so it enters the vein. It's got two channels, one in which blood is drawn out for dialysis, one in which it's returned. This is actually although it's the most convenient approach to dialysis, because show up and they just hook it up and you get your dialysis, it's also the most risky. It's the most dangerous, specifically relative to infection. It's, and I'll try to illustrate that a bit going forward here. Now, this is one of my favorite comics from the New Yorker from years ago. I'm actually embarrassed to say how many years ago. But at any rate, I propose that this is a dialysis patient talking to my surgery scheduler relative to the upcoming surgery. And he says, no, Thursday's out. How about never? Is never good for you? Well, nobody wants to schedule their access surgery, but I want to convince you that starting dialysis and being on dialysis by way of one of these catheters is very dangerous. And in fact, your life can depend on it. All right? I won't go into a lot of details on this slide, but this study involving a huge number of patients published in 2012 looked at the outcomes, some of the very bad outcomes potentially that can happen to patients when they are managed with a graft, a fistula, arteriovenous fistula, a catheter versus a graft, a catheter meaning the worst, the most dangerous approach, convenient but dangerous, versus the lowest risk approach of a fistula. Up here, there's not a huge difference. A value of 1.00 would be equivalence, okay? So if a graft had the exact same risk of a fistula, this would be 1.00. And without going into a lot of detail further, I would represent to you that when we move from entirely under the skin to outside the skin, plastic underneath the skin, outside the skin catheter to fistula, our risk rate goes sky high. Here there's a 38% higher risk of a heart-related event, 112% higher risk of major infection, and over a 50% risk of even mortality. Although there's certainly, with a huge study like this, there's going to be other factors. Range of age, the amount of diabetes involved and whatnot. But the bottom line is, for this to be subsetted out and to be this compelling, I think really makes the point very well. To end this slide on a positive note, there are plenty of studies that have shown that for patients that wind up getting transplanted, their rates of survival rise 75 to 80% compared to those who remain on dialysis. So getting on a transplant list is hugely important. This is a study that further looked at the differences between how patients do with a catheter versus a shunt, and we're going to lump shunt as a graft or a fistula into that group, meaning under the skin for dialysis versus outside. And even there's a statistically significant difference whether or not you're over 65 in terms of how you do as far as survival goes, or even under. So age, although people who are older don't do as well, this is a consistent finding of catheter being inferior to a shunt across the board. The same study looked at how do the individual populations do, those with a fistula, those with a graft. And it shows that in terms of patency, like how long it works, significantly better outcome with patients with fistulas as opposed to grafts. Survival as well, patients with fistulas, patients with grafts. It should be noted, however, that anywhere from 20 to 40% of created fistulas never mature, never get to the point of being able to be used for dialysis. But it's one of these settings in which it's better to have tried and failed than never to have tried before, because if we can get a patient with a functioning fistula, we're looking at better outcomes in patients with grafts and far better outcomes than patients who are managed with catheters. This recognition of the significant advantage of fistulas over grafts and certainly over catheters led the Centers for Medicare and Medicaid in 2003 to generate the Fistula First initiative that was so named in 2004. This advocates for the preferential placement of fistulas in patients, and media campaigns have been generated directed towards dialysis units, towards fistula, towards actual patients, and towards physicians themselves. Here we see a graph on the left which shows the rate of fistula placement between 1998 and 2007, during which time the rate of fistula placement rose to 56% overall, and over the same interval, the rate of graft insertion dropped down into the mid 20% range. The initial target of the Fistula First initiative was a 40% rate of fistula construction for patients. That was easily met. In 2012, the rate of fistula placement exceeded 60%, and the ultimate target is for a 66% rate of management of kidney failure patients with fistulas. I want to briefly talk about ultrasound monitoring and its importance. Once we've placed one of these fistulas into a patient or a graft, and particularly a fistula, this is a very sensitive structure. The vein, again, is not normally seen, very high pressures. And it's fairly common when you expose a vein to high pressures for those patients to develop either bubbles or aneurysms, to develop scarring and narrowing. And so it's important that patients follow up for their ultrasounds to make sure that we've got smooth, uncomplicated blood flow. This happens to be in a normal patient with a color flow on an ultrasound. And when we have this relatively even flow pattern of either red or blue, that means that we've got smooth, what we call laminar flow, and not disordered and represented in the other slide here, in which there's a patient with a graft, and I can tell that because it's got that double line there. Grafts usually show up that way. This patient has some smooth flow at the margin of this window, this red color, and then it transitions into multiple different colors. That's very suspicious because this indicates a lot of turbulence. Turbulence happens very commonly because, almost like a river, or a creek, if we put a bunch of stones along the edges at a certain point, we're going to create a lot of turbulence there. The blood flow is going to speed up a great deal, and commonly a patient with this picture of turbulence is also going to have a major acceleration. This might be in the range of 200 centimeters per second. With this patient here, actually was found to have a rate of flow of over 600, which indicates a major problem here. Fortunately, most of these narrowings can be managed with X-ray directed balloon treatments, and occasionally patients need to go to a surgery for a more significant repair. One very compelling study that was published in 2008 in the Netherlands looked at what were the major factors that influence the long-term function and patency, that is, of fistulas, and it was found that the two most important were the absence of diabetes, so patients who are diabetic don't do as well, but more importantly here, the presence of an ongoing surveillance program. Okay, that surveillance program can happen at your dialysis unit. The machines, they can set a VascuCheck, and there's a variety of other names for it, or in potentially in your surgeon or your doctor's office. I normally do an ultrasound every 4 months, just because these problems can come up fairly quickly. We want to catch them before it clots off, and we've got a much more complicated problem on our hands. I need to cover, for your benefit, fistula cannulation techniques. And now when I say cannulation, that's needles being passed into the dialysis access. In the first image here, we have what we call the area technique. And this accounts, let's apply this both to grafts and the fistulas. So the area technique is a circumstance where the one needle, which returns the blood flow to the patient, and the other needle, what we call the arterial, which draws the blood off to the dialyzer. These needles may be placed in multiple needles in a 1/2 to 3/4 inch or 1 inch length area, okay? This approach is to be discouraged. Whether or not it's a graft or a fistula, understand that if one places multiple needles over the course of weeks or months in the same area, it is going to weaken the structural integrity of the wall. This will promote dilation of the wall, bubble formation, or what we call in the trade aneurysms, and even put the patient at risk for rupture and major bleeding. Okay, that is the case, and so if a patient, a lot of times dialysis, what happens to the dialysis unit, patients don't feel like they've got control over, but this is your lifeline. It's got to be treated well to give you good long-term service. You don't want to get to know me any better than you have to. So it's to be discouraged. Rope ladder technique. The rope ladder technique also has application for both grafts and fistulas. Rope ladder technique is the distribution of those puncture sites along the entire length of the access. That is going to avoid the Swiss cheese effect of weakening the wall in one area and really prolong the successful use of an access. It can be a graft or a fistula. Finally, we have a buttonhole technique, which is more recently popularized. It is using the exact same site for the venous needle and the arterial needle. The feeling here was, one, we can avoid the problem with the weakening of the wall because we're hitting the exact same place and it's sealing up and whatnot. But also, if we hit the same place over and over again, we're going to deaden those nerves. It's going to be a more comfortable dialysis. And in fact, we have a study that pooled 23 different studies, a huge study that looked at rope ladder technique versus buttonhole technique. And it showed no statistically significant difference in the pain that was experienced by the patient. It showed no difference in how long the access would last either. And a little bit of a surprise, it showed a higher risk of local infection near the puncture site, but also throughout the body. This is thought to be related to the heaping up of scar tissue, dry skin, and the increased risk of compromised skin there developing infection. Now, what we've noticed in the vascular laboratory that we have at my home site, that it's not uncommon to have a patient, I don't know if you can see this, but patients who have the buttonhole technique can develop these nipple-shaped scar tissue underneath the surface, directly where the puncture site has been repeatedly over and over again. We call that hyperplasia. You can call it scar tissue. And here you can see that this can get much worse and create a complete blockage. In a cross-section of the exact same patient, we have a 40 to 50% blockage of our fistula. Now, I'm not necessarily in favor of one or the other. I'm happy if a patient has a buttonhole technique or a rope ladder technique. But what I advise the patient is to encourage the dialysis units to try to mature or to create 4 different locations, okay? 4 puncture sites, so that there can be an alternation of needle sites from one dialysis session to the other and back and forth. And you can understand mathematically that means that each puncture site is going to get half the amount of trauma, half the amount of punctures, and I would represent to you that the chances are half the amount of scar tissue and probably half the amount of potential infection related to this, to the access. Now, to finish up, I want to go into just a few cases that are of clinical challenge to me, and also try to address some of the fears and concerns that patients have that regularly present to my office with, I don't want my arm to look like that. So this is a patient who had a successful, this is a brachiobasilic, one of those more complicated fistulas created in his left upper arm. It was ready for dialysis, the patient went for dialysis, but unfortunately was found to have slow flows. He also developed, you can't see it here, but he developed swelling of the arm. We did an x-ray on him and found that in fact, where the blood travels into the chest veins, there was a narrowing in there, and that could not be treated with a balloon to try to open it up. So not wanting to lose a mature vein that at that time I believe was around 7 millimeters in diameter, which is a prized possession, we were able to take this vein out of the left arm, install it into the right arm. He has uncomplicated dialysis to this day, and the swelling, because there's not that flow, has all gone away in his left arm. Here's a patient with many years of dialysis through a very nicely functional upper arm fistula in his left arm. He's developed 2 aneurysms, one that's quite large over here. We didn't want to lose this. And in certain situations, not all situations, we're able to preserve the original fistula. In his case, we were able to remove some of the overlying skin, get down to the fistula itself, stop the blood flow, remove part of the wall of this bubble or this aneurysm. Here he is at the end of this operation, and here he is several weeks later and has good blood flow, and he's a very happy man. This is a more complicated circumstance in which a patient, who's actually a home dialysis patient, came in. He has multiple aneurysms along his left upper arm here, and in fact 2 sites, which you may appreciate, well, mostly right here, that look worrisome for the potential for rupture coming forward. This patient was taken to the operating room. We had a good vein in the other forearm, was able to create a fistula on that side. We returned to the operating room. We were able to tie it off the fistula, remove these, and here he is about a month after surgery, another happy man. Here's a patient with multiple aneurysms, an unsightly scar. It shows this because it would prove that this was in fact the same patient. Although because my Photoshop skills are not good, it is the same patient. And finally, perhaps a more complicated circumstance, we've got a patient here that's got major aneurysms of an upper arm fistula here. And when studied with X-ray, he had a complete blockage of the vein up in the chest. Now that might happen because they've had prior catheters up here, which can cause a lot of scarring. And slowly, with the high flows of these fistulas and the fact that we talked about, these are very fragile structures, not the fistulas so much as the veins. If we have high flows, we can develop these narrowings and these closures. That closure in the vein could not be repaired with a balloon or a stent. And the blockage there backs up. This fistula keeps on going and going. It backs up the arm, the entire arm swells, and you can even have this darker discoloration from the congestion of the venous blood in the arm. We were able to put a graft into his upper arm on the side. He didn't have any good veins remaining. And then returned into the operating room. We tied this off. We removed this fistula. And here he is a few weeks later. His coloration has improved, and he's having uncomplicated dialysis through the left arm. I hope that I've educated you, and I very much appreciate the invitation today.